There are two sets of challenges talking about prognosis. There are the obvious things. Medicine is uncertain. We can't predict what's going to happen to one particular person. And depending upon the kind of situation, there might be more or less uncertainty. And so there's a difficulty of predicting. But there's another set of difficulties that we often don't look at, which is the inner lives of clinicians themselves. So doctors want to help patients. We want to give them the best chance. We feel happier when they're doing better. We feel sad when they're not doing so well. And those are normal human reactions. I think when we're in clinical situations, we tend to think that we try to shield patients from that, from bad news, but also shield ourselves from feeling that sense of grief, that sense of loss, and the difficulty of explaining that maybe we don't know, maybe we're not completely sure. So it's in a way easier to reassure ourselves and reassure patients that everything's going to be okay.
Giving patients an idea of prognosis is always a little bit of a tricky situation. And there are a couple of reasons why. First off, I think we have known genetic predictors that may say patients may do better or worse overall, but that really takes into account historical data and doesn't really look at new treatments or novel sort of cutting-edge based approaches.
We are increasingly uncertain about whether a new therapy might be likely to yield an exceptional response, a really unusual, remarkable response in a patient. We're having more difficulty knowing how to communicate that. But if you step back for a moment from these new therapies and how they have made prognostication more difficult and communication of that information more difficult because of the uncertainty, really this is actually an old problem in cancer care that we hadn't solved, and now it's just being made more difficult by new therapies.
20 years ago, for example, when I was training in oncology and we were treating patients with metastatic lung cancer, regardless of which chemotherapy regimen we'd get them, the median survival was about the same, and sort of the range of how people did was about the same. But now, based on their genetics, which treatment they get, whether they respond to immunotherapy, the sort of range of possibilities are much more broad. So we can't sit with a patient and family and say, the majority of patients don't live a year. We have to say, well, if you have EGFR, you can live 3 years. If you respond to immunotherapy, you can live 5 years. And explaining that range of possibilities to patients and their families is challenging, and just takes time to explain to make sure patients and their families are informed and ready for any outcome.
Patients come to doctors for answers, but also doctors think that patients want certainty. And we overestimate patients' need for certainty sometimes, that by presenting what's known and what's not known, sometimes we can actually do better at gaining patients' trust than pretending that we know everything. Because patients will hear something else from somebody else, or they'll go on the internet, and soon they'll become confused and wondering whether they should believe us or believe someone else.
What we know from some of the older literature in the last 10 or 15 years is that really every study that has looked at this issue in patients with advanced cancer suggests that at least half of patients with incurable solid tumors and even with blood cancers think that their disease is curable in cases when their doctors know that it is not, unfortunately.
There was a study asking patients about prognosis and where they get information about prognosis, and what really shaped their own sense of how long they thought they would live. These were patients with cancer. And surprisingly, only about 20 or 25% of patients said that it was their doctor that gave them the best sense of, or the sense that they believed the most about how long they would live.
The level of understanding varies significantly between patient to patient, and many patients don't want to have a deep understanding. They want to put the burden of decision making and treatment on the physician and presume or hope that they're going to do what's best for them.
Shared decision making really is a process by which we first explain and share with patients that there is a decision to make, and then next talk about the actual choices, their risks, their benefits, the different nuances of those options, and then lastly explore who the person is, what's important to them, what are their values and goals and preferences, how do they want to make decisions, and then through the magic of communication in the exam room, we somehow come to a decision together that's right for that person in that particular situation. Some people mistake shared decision making to mean we share a bunch of information and then the patient makes the decision, and that actually really is kind of the antithesis to what shared decision making is.
I think the big thing that I remind my colleagues and trainees is that conversations about prognosis or the expected outcome with treatment and illness, they're not one-time conversations. One of the best things about being an oncologist is we see our patients all the time. We see them every few weeks to administer treatment. And so viewing these conversations as sort of part of longitudinal care, that if you don't have time to talk about it today, you can still address it in the upcoming weeks and months. And I think that's a better strategy for conversations about prognosis, is to view it as sort of a conversation that takes place over time rather than kind of hitting people over the head with it on one day.